Hi, my name is Isabel Virella-Lowell, and on behalf of ACHIA Asthma Learning Collaborative, I'd like to present asthma impairment and risk assessment. These are my disclosures. The objectives of this presentation will be to classify and document the level of asthma control during initial evaluation based on age-specific impairment and risk criteria. Review the control achieved and maintained through the NHLBI guideline. Restate the various tools for assessing asthma level of control, and review the various case scenarios for asthma control. Because asthma is variable in presentation, asthma severity should be considered when initiating therapy. From that point on, focus should be on monitoring asthma control. Control is achieved and maintained through a stepwise approach using the NHLBI guidelines. For determining severity and assessing control, criteria for 3 age groups have been established with impairment and risk domains. Impairment, or the severity of asthma prior to the initiation of therapy, includes assessment of day-to-day asthma symptoms, the impact of asthma on activities of daily living, the impact of asthma on lung function. Risk is assessed by determining the likelihood of future exacerbations, monitoring the progressive decline in lung function, and monitoring for adverse effects of medications. So in assessing impairment, you want to ask patients about how much asthma interferes with their normal daily activities. Is it affecting their sleep? Is it keeping them from going to school? Or affecting how hard or how often they can exercise and play with their peers? How often are they using short-acting bronchodilators for asthma symptoms? How frequently are they having symptoms? Are they occurring once a day, once or twice a week, or once or twice a month? And what is their baseline lung function? Features that are associated with increased risk in the future include poor clinical control of asthma, frequent exacerbations in the past year, any admission to a critical care unit for asthma across a lifetime, low FEV1, exposure to cigarette smoke, and high-dose medications. This chart represents the NHLBI guidelines for classifying asthma severity on initial visit. As you can see, there are 2 main categories of asthma, intermittent and persistent. Persistent is divided into mild, moderate, and severe. In the impairment domain, questions about the frequency of symptoms, of nighttime awakenings, bronchodilator use, and lung function are assessed. And in the risk domain, questions about the number of exacerbations are assessed. Depending on where the patient falls on this graph, you would begin therapy on step 1, 2, 3, or 4 of the NHLBI guidelines. Once you initiate therapy, the goals of asthma management are to achieve and maintain control of symptoms, maintain normal activity levels, including exercise, maintain pulmonary function as close to normal levels as possible, prevent asthma exacerbations, avoid the adverse effects from asthma medications, and prevent asthma mortality. Once a patient is on a medicine, you would evaluate the level of control on their subsequent visits. This graph represents how we determine control in asthmatics. Across the top are the categories controlled, not well controlled, and very poorly controlled. The domains you would question the patients about would include daytime symptoms, limitation of their activities, nocturnal symptoms and awakening, their need for rescue medicine, and their lung function. A controlled patient has daytime symptoms twice or less per week, no limitation of activities, nocturnal awakenings twice or less per month, and none if they're 0 to 4 years old. use of rescue medicine twice or less per week, and an FEV1, if obtainable, above 80%. Assessment of control also involves assessment of future risk, so the risk of future exacerbations and stability of their asthma, if they've had a rapid decline in lung function, and if they experience adverse events with their medications. An easy way to remember how to assess control is the rule of twos. Patients are controlled, have symptoms twice or less per week in the daytime, have nocturnal symptoms twice or less per month, and are using their rescue medicine twice or less per week. Additionally, they're requiring less than 2 doses of systemic steroids in the last 12 months. If they're 0 to 4 years old, they would need less than 2 steroid bursts in the last 6 months. It's important once you have started a patient on medicine and they come back and you evaluate control and make any modifications to those medications, that you reassess them every 1 to 6 months, depending on how severe their asthma is and how well or poorly they are controlled. There are several tools to help you in assessing asthma control. One is Asthma Control Test, or the Childhood Asthma Control Test, or ACT. The Childhood Asthma Control Test is for patients 4 to 11 years old, and the Asthma Control Test is for 12 and up. The Asthma Control Test is validated. A score of 20 or above represents adequate asthma control. For younger children, there's the Test for Respiratory and Asthma Control in Kids. This is for 0 to 4-year-olds, and a score representing control is 80 or above. There's some other tests available, the Asthma Control Questionnaire and the Asthma Therapy Assessment Questionnaire, and those are for children 12 and up and adults. This is an example of the Asthma Control Test. For 12 and up, there are 5 questions. The patient gives a score to each question depending on the frequency of their symptoms, and the score is totaled. And this is the example of the Test for Respiratory and Asthma Control in Kids, or TRAC. Again, 5 questions for parents to answer based on the frequency of symptoms. The score is totaled, and the physician can make a determination of whether the child's asthma is under control or not. Both of these tests are available online. So now that we've learned a little bit about how to assess control and how to assess severity, I'm going to go through a couple of cases. The first is a 10-year-old with a chief complaint of difficulty breathing when playing soccer with her friends. She often tires with activity. Each fall, she presents to her physician with cough, wheeze, chest tightness, particularly during viral illnesses. She awakens with cough 2 or 3 nights a week during the fall and winter, and often coughs with exertion. She uses her albuterol 3 to 4 times a week outside of exercise, and has had 3 exacerbations requiring a steroid burst in the last 12 months. There is a cat in her home and no tobacco smoke exposure. She has a past medical history of eczema that resolved at age 4 and mild allergic rhinitis that's been present since age 7. She does have a family history of asthma and has missed 4 days of school last year because of her asthma. Her review of symptoms is otherwise negative, and other than some boggy nasal turbinates, her physical exam is benign. Her FEV1 on spirometry is 75% predicted, which is below our desired goal of 80. Using the NHLBI charts for initial evaluation, given the child's frequency of nighttime awakenings, exercise limitation, and FEV1, and the fact that she has had 3 exacerbations requiring steroids in the last year, you can determine that the child has moderate persistent asthma. You would then determine treatment based on the NHLBI's stepwise plan. Second case is a 4-year-old ex-preemie with a history of moderate persistent asthma that has had 2 previous hospitalizations. His symptoms are worse now that he started daycare, and his mother notes that he awakens with cough 1 to 2 nights a week. He coughs and gets short of breath with exertion, and he is very active, so this is a problem. And he uses his albuterol inhaler 1 to 2 times a week. He is on an inhaled corticosteroid for asthma control via nebulizer twice daily. In addition to his asthma symptoms, he has a lot of rhinorrhea, itchy, watery eyes, and congestion. When assessing control using this chart, we can determine that he is not well controlled at present. His exercise is limited, and he is having more nocturnal awakenings than desired. So this child presents to your practice, and you determine that he's uncontrolled. What are the possibilities? The child could have poor inhaler technique, causing his lack of control. He could be non-adherent to his medications, causing lack of control. He could have inadequate treatment. There may be a need to step up his therapies. There may be an ongoing exposure to triggers that's making his asthma difficult to control, or comorbidity such as allergic rhinitis or gastroesophageal reflux that is making the asthma difficult to control. Once you determine the level of control, you can use this graphic to decide whether you need to step up or down in therapy. In a patient who's partially controlled, you should consider stepping up to gain control once you've eliminated the other possibilities we discussed as reasons for the lack of asthma control. If they're completely uncontrolled, step up is recommended regardless. In a patient who's been controlled well for 6 months or longer, you can consider stepping down therapy. The goal of asthma therapy would be to keep these children on the smallest dose of medication required to achieve good control. It is important to know, however, when we ask patients how they're doing and give them asthma control tests or other tools to assess their control, the patient's symptoms often don't match their perception of their control. In this study, in patients with severe symptoms, 32% believe their asthma was well controlled. In patients with moderate symptoms, 60% felt their asthma was well controlled. So obviously, assessing control requires more than asking a patient or a family member how the patient is doing, or even relying solely on the score obtained by your control tool. It's important to review those tools line by line with these patients to make sure that they've answered the questions correctly, that they've understood the questions, and that what they're telling you matches what they've recorded. Once the severity and control of asthma have been established, treatment of asthma is approached using a stepwise algorithm recommended by the NHLBI. The aim is to accomplish the goals of therapy with the least possible medication, and the choice of treatment should be guided not only by the level of control in their current treatment, but the pharmacological properties and availability of the various forms of asthma treatment and economic considerations, as many of these medicines are very costly and difficult for families to afford.